Welcome to the deep dive. Today we're going to be taking some pretty complex principles that really govern critical care.
And the goal is to boil them down into actionable knowledge.
Exactly. Our source material for this is the foundational medical reference, Applied Physiology in Intensive Care Medicine 1.
And this is a really critical deep dive for any medical learner. I mean, whether you're a student seeing these concepts for the first time.
Or a resident who just needs to solidify the why behind all those bedside decisions.
Right. We're not just summarizing guidelines. We're getting into the underlying physiology, the technical side of the measurements, and the key studies that define practice.
So the mission here is to move you beyond just, memorizing normal ranges and into a real analytical understanding.
We're covering the big four today: respiratory mechanics, gas exchange, hemodynamics, and neuromonitoring.
And everything we talk about really highlights how that minute-to-minute analysis of waveforms and pressures guides life-saving therapy. So let's start with the machine that breathes for our patients, the mechanical ventilator.
When you first approach mechanical ventilation, that airway pressure time graph, it's your most immediate source of physiological data, especially in volume control.
And it really shows you the work of breathing. So let's unpack the core pressures we'd see during a constant flow inspiration in, say, a passive patient.
Okay, so we start with the peak pressure, the P peak. That's the highest pressure you see.
The top of the curve.
Exactly. Then, if you perform an inspiratory hold, just a momentary pause, the pressure drops really fast down to the plateau pressure, or P-plat.
And that drop is incredibly informative, right?
It's everything. The difference between that peak and the plateau is your resistive pressure, P-res. That's the force needed to overcome friction in the airways and the circuit. It's the plumbing resistance.
So if P-res is high, we're thinking the patient's breathing tube might be kinked, or maybe they're having some acute bronchospasm.
Precisely. But then you have to ask, what about the force needed to actually inflate the lung tissue itself?
And that's the elastic component.
That's the elastic component. The pressure that's left over your plateau pressure, that represents the elastic pressure acting on the alveoli and the chest wall. That's the force that causes the stretching, the strain on the lung tissue.
So understanding this lets you immediately figure out if a high peak pressure is due to resistance, like a tube obstruction, or stiffness, like an ARDS or pulmonary edema.
As your first diagnostic branch point.
Okay, so speaking of things that complicate the picture, let's talk about PEEP-I, or inadvertent PEEP. A lot of people call it auto-PEEP.
It's a common and often pretty dangerous phenomenon.
It's trapped air, essentially.
That's all it is. PEEP-I comes from these flow-dependent pressure gradients between the alveolus and the airway opening. Usually it's just because the patient doesn't have enough time to fully exhale.
And that just raises the baseline pressure in the lung?
It does. Now, in a controlled ventilation setting, we can measure this pretty reliably with an expiratory hold or pause.
So when you apply that expiratory hold, what's physically happening that gives you a true reading?
Well, the hold closes the expiratory port, so it completely eliminates flow. With no flow, there's no pressure gradient. So the airway pressure has time to equilibrate with the mean alveolar pressure.
I see.
And the difference between that newly measured pressure and the PEEP you set on the machine, that is your PPI.
And that total pressure is what the patient has to fight against to trigger the next breath. It dramatically increases their work of breathing.
Exactly. Now, the source material points out a huge measurement challenge here.
Spontaneously breathing patients.
Right. Why does the standard expiratory hold fail in that case?
Their own muscles are active.
Their own respiratory muscles are active. So if a patient is actively trying to exhale, that muscle activity is going to skew your pressure reading during the hold. You'd be at risk of grossly overestimating the true alveolar pressure.
So what's the workaround? How do you get a reliable measure?
You have to measure the drop in esophageal pressure right before inspiratory flow starts. That lets you isolate the change in pleural pressure from all the airway dynamics.
Okay, that makes sense. This kind of leads us to respiratory system resistance, or RRs. Clinically, why is knowing the precise value of Rs so important beyond just figuring out the resistive pressure?
Well, we use it to accurately figure out why airway pressures are rising in volume control mode. Is it the endotracheal tube or is it the small airways?
And for interventions, I imagine.
It's the only way to really gauge the effectiveness of something like a bronchodilator. You give a treatment, you need to see a measurable drop in Rs.
Now, what's fascinating and I think often missed is the flow dependence of ours.
Yes, exactly. The source really emphasizes that ours is not a constant. It's actually maximal at low flow rates, and it decreases toward a minimum when the flow hits about 1 liter per second.
So if you try to manage a high peak pressure by just turning down your flow rate,
You might actually be artificially driving the calculated resistance up, which just complicates your whole assessment.
Yeah.
It demands a really careful interpretation.
let's shift gears a little to ventilator-induced lung injury, or VILI. We all know the old terms like volutrauma and barotrauma, but the source is stress. That villi is fundamentally caused by excessive stress. That's force per area and strain, which is the deformation or stretch that results.
And that physiological definition is so important because it moves our focus away from just absolute tidal volume.
And puts it on the vulnerability of the remaining healthy lung tissue. This is the famous baby lung concept.
So the baby lung is that small fraction of lung tissue that's still aerated and working in conditions like severe ARDS.
Correct. So the practical message here is that villi risk is really determined by the ratio of the tidal volume to the size of that baby lung. It's not just tidal volume divided by the patient's body weight.
So for a normal-sized patient with a tiny functional lung, a seemingly normal tidal volume could cause a huge amount of damaging strain.
Exactly. It completely challenges static protocols and really demands that we personalize ventilator settings based on things like compliance and imaging.
All right, let's move from mechanics into gas exchange. The idea of dead space, VLED, is foundational. It's the part of the breath that doesn't do any gas exchange. Right. And it breaks down into two parts. You have anatomical dead space in the big airways,
The VDAW.
and then you have alveolar dead space,
Yeah.
VDALV. And VDALV is the one that's physiologically critical. It represents alveoli that are getting air, but have minimal blood flow. You're just wasting the effort of ventilation.
The total physiological dead space is what we measure at the bedside, and we use the Enghoff modification of the Bohr equation. How does that actually work?
So the ratio is the arterial CO2 minus the expired CO2, all divided by the arterial CO2. You're basically comparing the CO2 in arterial blood, which reflects ideal alveolar gas.
To the CO2 in the mixed gas they breathe out.
Right. If they're nearly the same, dead space is low. But if your expired CO2 is much lower than your arterial CO2, it means a huge volume of CO2-free air is being exhaled, and that signals high dead space.
And a high ratio is a really bad sign in conditions like ARDS or a massive PE.
It's a known poor prognostic indicator.
Okay, that's the bedside standard. But for true scientific precision, the gold standard is the multiple inert gas elimination technique, or MIGET. This sounds intimidating.
It is pretty sophisticated. It involves infusing a solution of 6 different inert gases into the veins.
6 gases?
6. And by measuring their concentrations in both the arterial blood, that's retention, and the expired gas, that's excretion, we can deduce the exact distribution of ventilation perfusion ratios across the entire lung.
What's the unique insight that MIGET gives you that, a simple blood gas can't?
It lets us specifically identify O2 diffusion limitation. See, the inert gases we use, like sulfur hexafluoride and acetone, they reach equilibrium way faster than oxygen does.
Okay.
So if we measure a low arterial PO2 that cannot be explained by the VQ mismatch that MIGET has already identified, then the remaining deficit has to be due to slow diffusion of oxygen itself. It separates mismatch from true diffusion problems.
Let's tackle FiO2 and shunt. We rely so heavily on the P to F ratio, the PO2 FiO2 ratio, but the relationship is surprisingly complex. It's not linear.
It's absolutely not. The P to F ratio is influenced by the FiO2 itself, because oxygen changes how much VQ mismatch contributes to the total shunt.
So how does that work?
Well, when you give 100% oxygen, an FiO2 of 1.0, you maximize the oxygen tension in those compromised low VQ areas. This effectively knocks out the VQ mismatch component from your calculation.
And you're left with just the true anatomical shunt.
You're measuring the true shunt, and the source material highlights this with a really key visualization. For a moderate shunt, maybe 20%, the P to F ratio actually looks much better at high and low FiO2 levels than it does at intermediate values, like around 0.6.
So relying on a single ratio and an arbitrary FiO2 could be really misleading.
It can be. It just emphasizes that oxygenation failure isn't a static number. It depends on the physiological response to the oxygen you're giving.
Okay, let's connect the lungs to the circulation. Venous oximetry SVO2 and SCVO2 are arguably the best markers we have for the balance between oxygen supply and demand.
They're critical. Mixed venous saturation, SVO2, that requires a pulmonary artery catheter. It samples blood from the pulmonary artery, giving you the average O2 extraction from the whole body.
While central venous saturation, SCVO2, is easier, you just need a central line in the superior vena cava.
Right.
But is the difference between them clinically negligible?
Not in critical illness, no. SCVO2 mostly reflects extraction from the upper body, which is less metabolically active. The source notes that in something like septic shock, SCVO2 is typically about 8% higher than SVO2.
And that difference helps you differentiate shock states. Low values clearly mean not enough oxygen delivery.
Right, like in cardiogenic shock.
But what about the other way around? What if you see venous hyperoxia and SCVO2 greater than 80%? We know low is bad, but high has to be bad too.
High values are often a sign of a severe problem with tissue utilization. The tissues are getting oxygen, but they just can't extract it.
So what causes that?
It could be microcirculatory shunting, where blood is just bypassing the capillaries, or it could be severe mitochondrial failure at the cellular level. You see this in late-stage septic shock or after a prolonged cardiac arrest. The VO2 is just severely impaired.
Now, for the most common question in any ICU, will this patient respond to fluids? The sources are very clear. Static pressures like CVP or wedge pressure are unreliable predictors.
That really needs to be internalized by everyone. Static pressures just give you one snapshot of cardiac filling. They do not predict the stroke volume response. We have to use dynamic indicators.
Indicators that leverage the interaction between the ventilator and the cardiovascular system.
Exactly.
So let's focus on the two big ones: pulse pressure variation, PPV, and passive leg raising, PLR.
PPV is highly predictive. A PPV of 13% or more suggests the patient is preload dependent. It works because the ventilator cyclically decreases venous return, which leads to these swings in pulse pressure. If the patient needs fluid, those swings are large.
But there's a massive clinical caveat here.
A huge one, yes. PPV only works if the patient is fully relaxed on controlled ventilation, has regular heart rhythm, and normal intra-abdominal pressure.
So if the patient is breathing spontaneously, even a little bit, it's useless.
It loses its predictive power completely. The breathing effort just confuses the mechanics.
And that is exactly why passive leg raising is so powerful.
PLR is so reliable because it's a reversible, built-in fluid challenge. You just move the patient from a semi-recumbent position to having their legs raised.
And that shifts about 300 milliliters of venous blood from their legs into the central circulation.
Exactly. And if their cardiac output immediately increases by 10% or more, the patient is fluid responsive.
The crucial point being that this test has a very high predictive value, an AUC of 0.95, and it works even in situations where PPV fails, like spontaneous breathing or arrhythmias.
It is the gold standard dynamic test for predicting fluid responsiveness.
All right, our final segment, the brain. Let's look at intracranial pressure, or ICP, monitoring. The standard treatment threshold is around 20 to 25 millimeters of mercury. What technical details do we need to remember?
We have to remember the anatomical context. Where the ICP is being measured matters. There can be up to a 7 millimeter of mercury difference between an intraventricular and an interparenchymal measurement.
Which could reflect pressure gradients from, say, a mass effect.
Right, so you have to know exactly where that probe is sitting to interpret the number correctly.
And beyond just the number, the ICP waveform itself is a key diagnostic tool. It reveals cerebral compliance.
The waveform has 3 peaks. P1, the percussion wave, P2, the tidal wave, and P3, the dichrotic wave. Normally, P1 is the highest.
But as cerebral compliance starts to decrease,
The P2 wave elevates, often becoming taller than P1. When P2 is equal to or higher than P1, it's a signal of severely decreased intracranial compliance. Decompensation is imminent.
this brings us to the Cerebral Autoregulation Index, or RAP. This is a complex but vital measure of the brain's ability to maintain its own blood flow.
RAP is a mathematical measure. It's a correlation coefficient calculated between the ICP pulse amplitude and the mean ICP over short time windows.
And a positive RAP is a good sign.
A positive RAP correlates with intact autoregulation, which suggests a good outcome. The real clinical insight comes when RAP approaches 0, or even worse, becomes negative.
And what does a negative or zero RAP mean in a critical sense?
It signals the total breakdown of cerebral autoregulation. The brain is losing its ability to control its own blood flow. This often happens right before the final catastrophic collapse of the ICP pulse amplitude.
So it's a stark warning sign of impending brainstem herniation.
It's essentially an early warning system for regulatory failure.
Let's finish with cerebral oxygenation monitoring. Jugular venous oximetry, SJVO2, and near-infrared spectroscopy, NIRS.
SJVO2 gives you a global measure of oxygen extraction from the brain. Monitoring it is essential for detecting episodes of desaturation, and SJVO2 below 50%. which are associated with high ICP or systemic problems like hypotension.
And frequent desaturations predict poor neurological outcomes.
Strongly predict, yes.
And then NIRS gives us a non-invasive alternative.
It does. NIRS is regional. It uses light absorption to measure tissue oxygenation in real time. It's non-invasive, and it lets us track regional ischemia, which is particularly useful if you suspect a localized injury on top of a generalized one.
So we've done a really powerful deep dive here into the 4 physiological pillars of critical care.
We've covered a lot, from interpreting ventilator pressures to distinguishing shunt from VQ mismatch.
And rejecting static hemodynamic pressures for dynamic tests, and even interpreting complex ICP waveforms to anticipate cerebral collapse.
Mastering this foundational physiological data is what lets you move beyond just following protocols. It really enables precision medicine in the ICU, where every single decision is integrated with real-time objective data.
Before we sign off, here's a review exercise for you. Take a moment to synthesize the concepts we discussed about hemodynamics and oxygen utilization.
So, you have a mechanically ventilated patient in acute circulatory failure. You measure a pulse pressure variation, a PPV, of 20%, and a central venous O2 saturation, an SCVO2, of 85%.
Okay, so based on the physiological principles we just discussed, your task is to interpret these 2 findings, propose the most likely clinical state, and then suggest the appropriate next steps.
Think about what that high PPV is telling you about the need for volume and what the high SCVO2 indicates about the tissue's ability to actually use oxygen.
That was the deep dive. We'll see you next time.